The fields of orthopedics and traumatology are rapidly changing with the advent of new technologies and practices. But how can medical professionals ensure values are maintained in a time of building pressure? How can patient-oriented healthcare be maintained? To discuss these challenges, experts from around the world are meeting in Berlin for the German Congress of Orthopedics and Traumatology. In numerous sessions, talks and discussions over 4 days, they will connect with colleagues, learn more about new diagnostics, treatments and solutions for responsible patient care. At the largest European Congress in orthopedics and trauma surgery, 11,000 delegates will attend around 1,800 presentations on topics ranging from arthritis to trauma management, from complications to innovations. And to make sure you don't miss a thing, DKOU TV will be right here, bringing you the latest updates from the Congress. Welcome to the DKOU TV 2019. We're here at Messe Berlin to bring you insights into the latest developments in orthopedics and traumatology. We have an exciting program of interviews and in-depth reports coming up, focusing on everything from knee simulators to periprosthetic infection. We will be at the Congress every day to find out more about some of the sessions and events that are happening here, so stay tuned to find out more. But first, let's have a look at what's coming up on today's program. After an exciting first day, DKOU 2019 officially kicks off with the opening ceremony where the presidents of this year's Congress will welcome delegates to this year's meeting. Let's have a look what they have to say.
Wissen braucht Werte. So lautet unser gemeinsames Motto dieses Kongresses. Dass wir in den nächsten Tagen unser Wissen wechselseitig erweitern, davon gehe ich fest aus. Zumal man von hier oben Ihnen allen vortrefflich die spannungsgeladene Wissbegierde ansehen kann. Unser Wissen muss sich täglich im Wettbewerb mit Unwissen und einer Kultur des wissenden Ignorierens behaupten. Mehr Wissen reicht insofern heute nicht mehr. Wir müssen es öffentlich herleiten, begründen, nachweisen, überprüfbar machen. Wissen bedarf immer einer Einordnung. Werte liefern Maßstäbe zur Einordnung. Unsere Kliniken und Praxen sind in einem gesellschaftspolitischen Umfeld eingebettet. Je freier sich diese Gesellschaft aufstellt, desto freier können wir als Ärzte heilen. Wenn die betriebswirtschaftliche Effizienz und Leistungsfähigkeit über allem steht, hüllt dieser Wert die ärztliche Logik aus. Die heute so populäre Vereinfachung des Alltags führt zu populistischen Antworten. Wir Ärzte sollten uns als Komplexitätsmanager und nicht als Glieder in der Wertschöpfungskette Medizin verstehen.
Welcome to the DKOU TV studio, where I'm now joined by Professor Amaya. Very welcome.
Yeah, thanks for the invitation.
Thanks for being here. Professor Amaya, what are the key topics and trends in meniscus and cartilage therapy discussed this year at the DKOU?
So basically, when we're talking about the meniscus and the cartilage, we're talking about joint preservation, which is definitely a topic which gains of relevance since middle-aged or even older patients are more and more active, and our ultimate goal is actually to avoid any kind of total joint replacement. What we definitely will be discussing this year is the importance of the meniscus. We have really had some new publications that show that the meniscus is not only a buffer in the joint, but it's only relevant for stability. We know much about the interaction between the meniscus on the one hand side and the cartilage on the other hand side, and I'm really looking forward to join these sessions.
So what are some of the key challenges in current therapy of meniscus and cartilage conditions?
So when talking about the meniscus, definitely the goal is to preserve the meniscus somehow. In former days, we have performed many surgeries in which resection of the meniscus or partial resection was performed, and the strategies how to improve our healing rates when meniscus refixation is performed is definitely a topic which is important. Biological augmentation, and as I said before, the interaction to the articular cartilage.
Why is this topic for you interesting, privately, personally?
I'm also a sportive person. I want to stay active even once I'm getting older, as everybody of us is. And I strongly believe that initial trauma, for instance, is one of the key parameters which might induce an osteoarthritis. And therefore the strategies to deal the initial injury is definitely something which I'm personally also interested in.
What are your predictions for the future?
So what we learned referring to cartilage repair strategies, we have introduced some really innovative treatment options in recent years. For instance, autologous cell transplantation, which has been introduced in the 90s. And we have also introduced, talking about the meniscus, about complex suturing techniques and refixation techniques. And bringing these together is definitely something which I believe is a challenge for the future. Early osteoarthritis, so when degeneration begins in a joint, is definitely something we have to overcome, because that's still the major limitation of every kind of joint preservation.
So if we take a look back to the last 20 years, what was the most important step in this topic? What do you think?
In my opinion, actually the most important step was that we learned to deal with acute injuries somehow, talking about cartilage repair. But we never really learned to deal with chronic injuries and chronicity, inflammation in the joint. And that's, as I said before, the challenge which I consider most important for the future.
That's good. So we are on a good way, but there's a lot to go.
And we will start here in Berlin.
Very good. Thanks for joining us.
Thanks for being here.
Next up, we take a closer look at the Institute of Orthopedic Research and Biomechanics at the Ulm University Medical Center, where researchers focus on a broad research spectrum, including bone regeneration and joint biomechanics.
Unser übergeordnetes Forschungsziel hier im Haus ist die Erforschung von Störungen der Funktion und Regeneration muskuloskeletaler Gewebe. Natürlich mit dem Ziel, die Grundlagen besser zu verstehen, in die Klinik zu transferieren und letztlich verletzten und erkrankten Patienten helfen zu können. In unserem Institut arbeiten derzeit ungefähr 40 Mitarbeiter. Dazu kommen etwa 20 Studenten und Doktoranden. Wir sind hier im Haus ein sehr interdisziplinäres Team. Es arbeiten hier Biologen, Molekularbiologen, Mediziner, Tiermediziner, Ingenieure, Informatiker, und dadurch kommen natürlich sehr viele verschiedene Expertisen zusammen. Und wir haben ein sehr breites Portfolio an Methoden für unsere Forschungsarbeit zur Verfügung.
Unsere Forschungsschwerpunkte im Bereich Knochenbiologie sind, dass wir verstehen möchten, wie der Knochen auf- und umgebaut wird. Außerdem möchten wir die Pathomechanismen von altersassoziierter und postmenopausaler Osteoporose besser verstehen können. Außerdem möchten wir verstehen, wie mechanische Reize auf den Knochen wirken und uns dies auch therapeutisch nutzbar machen. Im Bereich Knochenregeneration interessieren uns die molekularen Grundlagen der Knochenheilung. Eines unserer Hauptziele ist, besser verstehen zu können, wie Begleitverletzungen und weitere Traumata die Knochenheilung beeinflussen können. Im Bereich Knochenforschung verwenden wir, um molekulare und zelluläre Mechanismen aufzudecken, in vitro verschiedenste Zellkulturmodelle und in vivo können wir transgene Mausmodelle nutzen. Außerdem machen wir histologische und biomechanische Analysen und uns steht ein hochauflösendes Mikrocomputertomographiegerät zur Verfügung.
Ich bin verantwortlich für die Forschung zur Bandscheibe, Meniskus und zum Knorpel. Die Forschungsschwerpunkte sind es, die Degenerationsmechanismen zu verstehen, Möglichkeiten der Regeneration zu finden und Therapiekonzepte zu verbessern. Eine Besonderheit unserer Forschung hier ist, dass wir ganz speziell entwickelte Modelle haben, in denen wir diese hohen Belastungen, die in diesen Geweben vorherrschen, simulieren können. Ein weiteres wichtiges Ziel ist es auch, neue diagnostische Marker für die Behandlung dieser degenerativen Krankheiten zu entwickeln und zu finden. Hohe Dehnungsapplikationen können wir machen, wir können hydrostatischen Druck applizieren. Und eine Besonderheit ist, dass wir mittlerweile auch viele Versuche im Organkulturmodell machen. Das heißt, wir haben Modelle, mit denen wir Gewebestrukturen für längere Zeit am Leben erhalten können, im Labor, unter Laborbedingungen. Und dann dieses Zusammenspiel von Belastung und Entzündungsprozessen beispielsweise simulieren können.
Ich leite den Bereich Gelenkbiomechanik hier im Institut. Der Hauptfokus liegt auf dem Kniegelenk. Speziell haben wir uns in den letzten Jahren auf den Meniskus gestürzt. Wir haben hier im Institut verschiedene Gelenksimulatoren entwickelt. Einen traditionellen, der mit relativ langsamen Bewegungen funktioniert und geringen Gelenkkräften. Das hat uns aber nicht ausgereicht. Deswegen haben wir in einem großen DFG-Projekt einen neuen Gelenksimulator konstruiert und haben dabei festgestellt, dass unter großen Belastungen und auch schnellen Bewegungen sehr viel höhere Kräfte entstehen. Zusätzlich zu den Gelenksimulatoren können wir Bewegungen analysieren mit speziellen Kamerasystemen. Wir können aber auch Gelenkflächen zum Beispiel biomechanisch abscannen. In Zukunft werden wir uns speziell auch auf die Rehabilitationsforschung stürzen und das können wir eben mit unserem neuen Kniegelenksimulator sehr gut machen.
Ich leite die Wirbelsäulenforschung bei uns im Hause. Ziel unserer Arbeit ist es, dass wir versuchen, die knöchernen Strukturen, die Bandscheibenstrukturen einer degenerierten oder verletzten Wirbelsäule zu verstehen, um dann Therapieverfahren oder Operationsmethoden zu entwickeln, zu verbessern oder neue uns auszudenken. Hierfür haben wir eine ganze Reihe von Belastungs- und Bewegungssimulatoren, um diese dann experimentell mit unseren Finite-Elemente-Methoden zu untersuchen. Wir versuchen in unserem dynamischen Wirbelsäulenbelastungssimulator ganz aggressive Bewegungen zu simulieren, die vielfach wiederholt werden. Und wir können damit unter aggressiven Testmethoden Bandscheibenvorfälle erzeugen, wie sie beim Patienten tatsächlich gefunden werden.
Wir freuen uns sehr, dass wir dieses Jahr einen großen Forschungserfolg erzielen konnten. Der Wissenschaftsrat hat uns ein Forschungsgebäude bewilligt zum Thema multidimensionale Traumawissenschaften. An der Antragstellung waren natürlich viele Kollegen hier am Standort beteiligt. Herr Professor Huber-Lang aus dem Institut für Traumaimmunologie und ich sind die Gründungsdirektoren dieses neuen Forschungsgebäudes. Zwischen 15 und 20 Arbeitsgruppen werden zu Fragestellungen der Traumaforschung zusammenarbeiten. Grundlagenforscher wie klinische Forscher, multidimensional vom Molekül über die Zelle bis zum Organismus und wir interessieren uns auch für die Interaktionen von physischem und psychischem Trauma. Nächstes Jahr feiern wir unser 30-jähriges Bestehen hier am Standort Ulm. Wir freuen uns, dass wir über die vergangenen Jahre gute Forschungsarbeit geleistet haben und unser Ziel ist es natürlich, das auch in Zukunft zu tun. Das Institut ist über die letzten 30 Jahre stetig gewachsen, die Mitarbeiterzahl ist vergrößert, die Forschungsbereiche sind ausgeweitet, sodass wir für die nächsten Jahre keine Angst haben, dass uns die Themen ausgehen.
I'm joined now by Dr. Kleber and Dr. Stewie. We're talking about the new developments in acetabular surgery. Very welcome. How are you?
Fine, thank you for the invitation.
Thank you very much.
We're happy to have you here. So what are the new developments?
So first of all, in the last decade, big improvement was achieved due to surgical approaches We have two very new interpelvic approaches, the stopper approach and the pararectus approach, which help us to do a proper reposition and address acetabular fractures from interpelvic region. The second thing is that we have technical advancement like 3D imaging and navigation, which we can use for minimal invasive techniques to address these severe injuries.
We also have some improvement in the implants we use. For example, do we have the chance to have anatomical preformed implants which we can put onto the fracture after the reduction, which help us to have a good and proper reduction after the surgery. And due to those implants, we also have a better hold of the fragments, and that of course makes it easier to move the patient after the operation. So we have the possibility of a very quick recovery, and this is due to new implants which we use.
So what consequences are these changes going to have on treatment pathways and patient outcome?
So minimal invasive techniques has the power to reduce perioperative morbidity like blood loss, operation time, and therefore we hope that the quality of life and actually the socio-economic burden is diminished and survival improved.
Sounds very good.
Yeah, we hope that it works. So far we don't have real proof of that because it's very difficult to compare the different patient groups. But in future we hope to get something like that. In former times this operations or this injury was something which made older people die because of this, and now we have the possibility of getting them back to normal life.
And the more treatment options we have, the better we can individualize the treatment plan.
So get safer?
Certainly the operation itself is a safer procedure compared to 20 years ago, but of course there's still a risk, and all patients of course are frightened of dying or having severe other complications. And of course we are not able to give them any guarantee that it doesn't happen, but with an experience in anesthesia and an experience in surgery, we can improve that. And we have a lot more of experience with those new approaches, which also diminish the time we need for the surgery itself. And nowadays it is normal that we only use maybe 2 hours for acetabular surgery, and 20 years ago the normal acetabular surgery was 4 or 5 hours.
The task in the future will be how to properly allocate the patients to the individual treatment plan. And this is directly connected with risk factors for secondary coxarthritis. And therefore we have to rethink about reconstructing minimal invasive techniques or total hip implantation. And this will be the task to select the proper patients for the proper treatment in the future.
Do you think there are any challenges in acetabular surgery that need to be overcome still?
Yes, as he already said, I think there's still two different approaches. One from the orthopedic side, who is very used to do arthroplasty for a fracture in the hip or in the acetabulum. And the other one coming from trauma surgery, which has the aim of restoration of the acetabular joint and rather not restored with a total hip arthroplasty. And we still don't know when we use which procedure. So we need to have a trial for that, and I think we need to have a very good multi-center study or maybe even multinational study to find out which is the proper treatment, as he said.
We discussed this actually in a lecture today, and the idea was born to create an individualized treatment plan adapted to prognostic factors for secondary coxarthrosis, and to validate this treatment protocol multi-center study randomized prospectively.
With the aim that after we have the results of that study, that we can tell people who don't treat as many of those cases as others do, that they just need to have to check fracture type, age, other illnesses, and then they know either to do arthroplasty or either to do osteosynthesis or maybe a combination of both.
And we know from trauma surgery and trauma network that standardizing trauma management has an improvement of the quality.
Very important topic. Thanks for being with us.
Thank you.
Next up is the Department of Orthopedics and Traumatology at the University Hospital of Basel. The department stands out due to its strong team spirit and interdisciplinary collaborations with experts from other fields.
Wir sind hier am Universitätsspital Basel, der Klinik für Orthopädie und Traumatologie. Wir haben derzeit 7 verschiedene Teams. 3 davon sind wissenschaftliche Teams. Des Weiteren haben wir auch interdisziplinäre Teams wie das Infekt-Team oder das orthogeriatrische Team. Ein wichtiges Merkmal unserer Klinik ist, dass wir die organisatorische Trennung von elektiven und akuten Patienten beibehalten.
Was die ärztliche Arbeit betrifft, arbeiten wir aber eng zusammen. Wir haben gemeinsame Rapporte, wir haben Rotation innerhalb der Teams.
In unserem Team, Team Oberextremität und Team Unterextremität, haben wir 4 leitende Ärzte, 6 Oberärzte und 6 assistente Ärzte. Wir haben ein Pheno, womit wir normale Röntgenbilder aufnehmen können, aber auch 3D-ähnliche Bilder unterwegs während der Operation aufnehmen können. Es gibt uns die Möglichkeit, die Patienten besser zu versorgen und eine präzisere und bessere Reposition zu erreichen. Zur Behandlung von komplexen Frakturen haben wir die Möglichkeit, einen 3D-Druck von einer Fraktur zu machen. Das ist eine Pilonfraktur, ein Dachdecker, 4 Meter gestürzt. Nun machen wir einen 3D-Druck 1:1 und wir können dann die Strategie ganz präzise und genau festlegen, bevor wir im OP gehen.
Und was wir im 3D-Printlab machen, ist aus den Computertomographiedaten ein dreidimensionales Modell des frakturierten Knochen oder der gebrochenen Knochen zu berechnen. Und aus diesen dreidimensionalen Daten kann man dann ein 3D-gedrucktes Modell herstellen.
Der Fokus für unser orthogeriatrisches Team ist eindeutig die klinische Tätigkeit, die individuelle Betreuung des geriatrischen Patienten praktisch umzusetzen. Das umfasst zum Beispiel ein Delir-Screening, es umfasst ein Management von Malnutrition, eine standardisierte Osteoporoseabklärung, ein standardisiertes Schmerzmanagement, die wir speziell für die geriatrischen Patienten definiert haben. Traumatologe und Geriater gehen gemeinsam jeden Tag zum Patienten und beurteilen ihn. Wir haben auch einen kontinuierlichen Patientenpfad implementiert, sodass die Betreuung von hier, der Akutstation, bis in die nahegelegene orthogeriatrische Rehabilitationseinheit gewährleistet ist.
Das Team für orthopädische Infektionen konzentriert sich auf alle ambulanten und stationären Patienten, bei denen es zu einer Infektion im Bereich des Bewegungsapparates gekommen ist. Es braucht bei praktisch allen Patienten die Kombination des Chirurgen und des Infektiologen.
In der ambulanten Sprechstunde da sehen wir die Patienten mindestens zu zweit, meistens zu dritt. Ein Orthopäde, ein Infektiologe und ein plastischer Chirurge.
Es ist in der Regel eine operative Therapie vorgeschaltet mit der entstehenden Diagnostik und der Behandlung des Infekts, der Stabilisierung von Knochen oder dem Austausch von Kunstgelenken und im Nachgang dann die Behandlung interdisziplinär mit Antibiotika.
In der Forschungsgruppe beschäftigen wir uns mit, wie Zellen sich organisieren können, um Gewebe zu züchten als Implantate für die klinische Translation. Insbesondere im Fokus von Geweben vom Bewegungsapparat, Knochen und Knorpel, um reproduzierbar diese Knorpelzellen zu züchten auf dreidimensionalen Gerüsten, um Gewebe zu generieren, die biochemisch, biomechanisch funktional sind.
In unserem großen Nase-zu-Knie-Projekt führen wir aktuell eine multizentrische Studie durch. Wir haben große Hoffnung in diese Therapie für die Zukunft. Erkrankungen am Knie wie fortgeschrittene Arthrose, die wir bis heute nicht gut behandeln können oder wofür man dann ein künstliches Gelenk implantieren müsste, hoffen wir, dass wir das in Zukunft auch regenerativ mit solchen gezüchteten Knorpelkonstrukten behandeln können und damit Patienten auch helfen können. Wir haben bereits 2 Patienten schon mit fortgeschrittener Arthrose als Einzelfälle behandelt und haben hier sehr gute klinische Ergebnisse erzielen können.
Vor der Operation war es dann wirklich so schlimm, dass ich wirklich die Treppe hochgekrochen bin. Ich wusste für mich eigentlich in dieser Situation, ich habe eigentlich nichts mehr zu verlieren. Man hat mir dann hier in der Nase den Knorpel entnommen, den wir hier reingemacht haben. Seither kann ich problemlos spazieren gehen, also ohne Probleme auch mal Stunde, 1,5 Stunden. Ich sage ihm, ich habe wie ein zweites Leben bekommen eigentlich.
Der Fokus in der Weiterentwicklung unserer Klinik wird sicher auf der Optimierung unserer Behandlungsabläufe liegen. Wir verlegen die Behandlung, die ambulante und die stationäre Behandlung unserer elektiven, orthopädischen, planbaren Patienten ins Bethesda-Spital.
Der Fokus der universitären Orthopädie am Standort Bethesda ist primär das ganze Spektrum der Orthopädie. Das Besondere der Abteilung ist eigentlich, dass wir hier das Beste von zwei Welten anbieten, der Public-Private Partnership. Wir haben einerseits das individuelle Umfeld des Privatspitals für die Patienten, andererseits aber auch die universitäre Orthopädie, die hier einen 24-Stunden-Service bietet, mit der Qualitätssicherung, die man von einem öffentlichen Spital kennt.
Die Auftrennungen elektiv und Notfallbehandlungsabläufe birgt natürlich ein bisschen die Gefahr der Aufsplitterung der Klinik. Wir sind aber so organisiert, dass die Spezialisierung im Fachlichen erst ab Stufe Kaderarzt stattfindet. Die Assistenten und die Oberärzte sind in einem Rotationssystem organisiert. Wir sind hier eine Universitätsklinik und wir nehmen diese Verantwortung sehr ernst. Wir sind überzeugt, dass die Weiterbildung ein Wert an sich ist, nach dem wir uns richten. Und man kann sogar sagen, die Weiterbildung ist eigentlich das, was unsere Klinik zusammenhält.
I'm here with Dr. Müller, Professor Zagroa, and Professor Heller. Nice to have you here.
Thank you.
We are discussing treatments of periprosthetic infections. What would be the normal treatment approach for periprosthetic infection?
So it depends on the type of the infection. If you have an early or late onset infection. So if you have an early infection, you can do a revision with removing the movable parts of the prosthesis. And then you close the wound, do some antibiotics. If you have a late onset infect, you have to remove the prosthesis.
How important is it to involve experts from other departments in the treatment?
The treatment of periprosthetic infection is a teamwork, so you have to include other departments.
Which departments?
Infectivologists, microbiologists, in case anesthesists when you have to treat complicated patients. These are complicated patients, a risk for their life, because the mortality after a severe periprosthetic fracture can be a big problem. These are fragile patients, so it's absolutely a teamwork.
Are you seeing a rise in periprosthetic infection, and if so, what do you think are the reasons for this?
I would say yes, we see a rise in periprosthetic infection. I think there are two reasons. First reason is our population getting older and older, so there's also a need for more implantation of prostheses for the knee and hips. So in total the number increases, and with that the number of periprosthetic infection. And the second reason is our diagnostic tools are getting better and better. So that means what we thought 10 years ago, it is an aseptic failure or loosening. This is meanwhile more an infection problem, because we see with special tests we developed more and more infection behind the reason of pain or loosening.
Okay, which tests, for example?
We have a lot of biomarker tests meanwhile, so that means, for example, alpha-defensin test is new. We're looking more detailed for the cell count. We now, meanwhile, that we have prolonged our incubation time. 15 years ago, we just looked for 3-5 days. Meanwhile, we have to wait for 12-15 days for the incubation that all bacteria are growing, because most of them are low-grade infection with low growing rates. So lots of things we specialized and see that we give the blood, the aspiration to blood bottles, so and make sure that it's very fast to the microbiologist laboratory. So lots of things we improved, and with that we see more and more infection by a better diagnostic.
And the key point is for us as surgeons, the prevention of this, of course, because once the infection starts, it's very difficult to treat. It's always a failure, always. It's always something that you lose. So the key point is prevention and optimization of the patient to be ready for the good surgery.
But very
what is very important is what he pointed out. So the rate of detection of infection is much higher than before. And that might be the reason why the rate is higher. Yeah? The rate of infections is higher in the registers, yeah? Because the detection is much higher. It's important.
So what changes in the treatment approach would you recommend because of that?
First of all, I recommend very careful diagnostics. Each failed implant must be considered infected until it's proven the opposite. So you have to look at this as a first line reason for failure in case of painful prosthesis, in case of unexpected loosening. And then all the developments in our field are going in this direction, improving treatment, improving the possibility of using local antibiotics, for example, which is very important. So we are not at the beginning, but we have a long way to go.
Thank you very much, gentlemen. Have a good time at the Congress.
Thank you.
Up next, we take a closer look at trauma care in the southwest Netherlands. Find out more about the work of Trauma Center in the region and the trauma department of Erasmus MC.
The Trauma Center is an organization responsible for the trauma care in our region. There's one level 1 trauma center. This is the Erasmus Medical Center. We will see each year about 450-500 polytrauma patients. In the Netherlands, we have 4 helicopter medical teams, 1 in Rotterdam. As a level 1 trauma center, we have all physicians staffed on the helicopter medical team, and they are very experienced in trauma care and non-trauma care but for critical ill patients.
I started with a project of providing pre-hospital thoracotomies, which is quite unique for the Netherlands. We now are researching if REBOA, resuscitative endovascular balloon occlusion of the aorta, is another option. The average rates of survival for emergent thoracotomies are similar to South Africa and the USA, and that's mainly due to the collaboration we have with our Ministry of Defense.
The Erasmus Medisch Centrum has a close and very active collaboration with the Ministry of Defense, with the armed forces. We bring our war experience to the hospital and can use that in this very large trauma center. Also, we can keep our skills up to date, obviously. So we work with everybody, and we normally work in white, like everybody else here.
In the Netherlands, the trauma surgeon is head of the trauma team, and he is experienced in fracture care, but also in soft tissue and thoracic and abdominal trauma. We do damage control laparotomy or resuscitative thoracotomy, and also intervention radiology is possible 24/7 a day.
We do a stabilization in the ER department, and subsequently we have OR facilities at the ER, in the OR. We have intensive care units or in stable patients a ward. The team consists of 8 consultant trauma surgeons, so we are quite a large team, but on top of that we have pillars, certain specific expertises, and we have organized that in teams who take care of specific parts of the body.
In our hospital we see many multi-traumatized patients, so we have a very low threshold to do a CT scan of the thoracic cavity. I'm especially focusing on the presence of rib fractures. Rib fractures are, up to me, underestimated, and we need more data on how to treat these fractures. That's why we set up a multi-center randomized controlled trial for multiple solitary rib fractures, to operate on them, and the other arm we don't operate on them.
We see approximately 80 to 100 patients with a pelvic injury a year that need surgical treatment. And we have a hybrid OR in which we can perform minimally invasive treatment with high-end, high technical resolution and software that provides us the possibility to be very precise in what we do.
We have done some RCTs, a randomized controlled trial on proximal humeral fractures. And for example, for elbow injuries, instability of the elbow, we will treat this with an external fixator, a dynamic one, with immediate mobilization afterwards, because we like to prevent stiffness. And we have very good outcome and satisfaction of these patients.
With regard to lower extremity, especially the lower leg, we have an excellent collaboration with our plastic surgeons, and even in the middle of the night or at the weekend we have the opportunity to do a definitive treatment in a very early phase. We have research projects going on, for example, the effect of certain nailing techniques with regard to complaints on the long term. We also have been involved in the development of specific new implants that are antibiotic coated.
One of the other projects we started about 2 years ago is the osseointegration program. The procedure of osseointegration is when we use titanium implant. The femur is reamed to the diameters of the implant, and the implant is put press fit into the femur, and then by partial loading the bone will grow into the implant, and then the patient is able to move his prosthesis and there's no need of a socket anymore. Surgery is only a minute part of the procedure. Real work for the patient, the rehab program, it takes about 3 months at least.
We have a collaboration with the Technical University of Delft to see if they walk better, just the quality of walking, and if they can walk longer. We also do training programs within Europe to learn how to do the osseointegration procedure and the screening before the surgery and the rehabilitation program afterwards.
I had an operation 2 years ago and I'm happy with it, what I have now. With the other operation that I have, the symptoms was very painful. With this you can walk freely. I can on the bike, I can shopping, I walk on the stairs. The quality of life is back to me. The socket is gone and the pain is gone.
We also see many patients who are referred from other hospitals with problems with fracture healing, like infected non-unions or bone segment defects. This is a circular fixator which you can use with an infected non-union, for example. Also in patients who have a post-traumatic limb deformity. And then with the rings and a computer model we can adjust the position of the fracture. There are not many hospitals in the Netherlands doing this, so I'm quite proud to be able to do this.
We are also participating in international education programs. We are running courses together with international colleagues. We are also going to visit other hospitals to stay in the front line of the treatment of trauma patients.
I'm now joined by Professor Rödel to find out more about the newest developments in pediatric orthopedics. Welcome. Thanks for being here.
Yeah, thank you very much. It's very nice to talk to you and to talk about the basic topics in children orthopedics.
That's right.
And in fact, during the last years, we come back to the roots of pediatric orthopedics, because pediatric orthopedics is to guide growth. And we have now two topics, that's guiding growth and creating growth, which we really empower now. So guiding growth means that we manipulate the epiphysis, the growth plates, to grow into the correct way. And a lot of new implants were developed during the past years. And they work at the growth plates near the knee, but also at the spine. So scoliosis is now trying to be treated guiding the growth of the spine. And as well, the leg, the deformity of legs is now treated guiding the growth. And the other big topic is creating growth. We have now implants which can move inside the body, which is completely new and which is terrific. So if you put something into a bone, it's very far away from outside, like the moon. It's a big distance. And it's very difficult to steer something which is in the body. Now we have a new technology based on magnets. So a magnet outside is creating movement inside. So we can distract bones, we can distract the spine. The year before, it was very difficult to lengthen a bone. We need external frames and a very demanding procedures. Now we can put in a nail inside, a growing nail, and we can steer the nail from outside with a magnet, and we create growth. Now we lengthen bones in a much more comfortable way for the patient than we did before, and we also use that technology for the spine. With distracting rods, we can correct the deformities of scoliosis. So I think these are the two big topics: creating growth and guiding growth.
This is very interesting and a very, very, very important step forward.
Yes, I think in children orthopedics, we had a huge development, and it's a game changer. It's completely different what we are doing now compared to the past.
What is for you one of the most interesting topics here at the DKOU this year?
I'm very happy to be here and to meet all my colleagues in this special atmosphere.
What developments do you foresee for the future?
So this creating growth is not finished. The implants become smaller and smaller. If you want to lengthen a bone in a child with open growth plates, we can't insert a nail. We will ruin the growth plates. But now it is worked on growth plates. That means you put a plate on the bone and you can distract it, so you don't have to rush through the growth plate. So I think this development is not finished, and these implants will become more and more clever. They will measure something. They will measure the forces on the implants, and that will optimize our treatment.
30 years back, was there a possibility like this or just a dream?
30 years back, people tried to develop such instruments. We have patents, and I was in this team all my time, as long as I did pediatric orthopedic surgery. And they tried, but the distance, as I said before, between outside and inside the body, only for a few centimeters, but like birds to move. It is so difficult to have a proper, reliable technology which really moves the things inside. And that was the work of the last 30 years. So it was a dream, and now we have a real solution which is really working.
That sounds very good. Thanks for joining us.
Thank you.
That's it for today from us here at DKOU TV. It's been a busy first day here at Messe Berlin, but it's just the start. Tomorrow we will talk to the president of this year's DKOU to find out more about their hopes for the Congress, so make sure to tune in again. Remember, you can watch the show in a whole host of ways right here at the Congress, in your hotel room at select hotels, and of course online via the DKOU 2019 website and our YouTube channel. We will see you tomorrow.